Hello viewers, this is Dr. Rajiv. Welcome to your education channel, YouTube Surgery and Orthopedic Education. Please consider subscribing to it as well as share it to your near and dears to help them in their preparation of MBBS course as well as other postgraduate and job entrance examinations. Also, please don't forget to press the bell icon below so that you never miss an update from us. The Perthes disease is a rare variety of aseptic, non-inflammatory, self-limiting and idiopathic avascular necrosis of captor femoral epiphysis in a child. It can lead to progressive permanent femoral head deformities and premature osteoarthritis. LCPD was first described by Legg, Calvé and Perthes independently in 1910. Hence, it is also known as Legg-Calvé-Perthes disease or LCPD. Even more than 100 years after the description of Legg-Calvé-Perthes disease, the etiology remains unknown and a great deal of confusion exists regarding the treatment of this enigmatic disease. Perthes disease is a form of osteochondritis which affects only the hip. The condition is most commonly found in children between the ages of 4 and 8, but it can occur in children between the ages of 2 and 15 years also. Male children are 3 to 5 times more commonly affected. The peak age of onset is around 8 years of age. Approximately 10% of cases are bilateral. The cause of LCPD is not known. LCPD is a multifactorial disease. Environmental, metabolic, and genetic factors are supposed to be involved. Risk factors involved in the pathogenesis of Perthes disease could be low birth weight, delayed skeletal maturation, short stature with rostral sparing, and last but not the least, socioeconomic deprivation. Condition may be associated with genital urinary tract abnormalities, inguinal hernia, and minor congenital abnormalities. Epidemiological studies reveal a positive family history in about 10% of cases. There is a high association of breech or transverse lie in mothers of affected children. There are also racial and ethnic factors. Perthes disease is found to be more common in Japanese, Eskimos, and Central Europeans. An increased incidence of LCPD is seen in later born children, particularly the 3rd to the 6th child, and in lower socioeconomic groups. The most widely accepted theories point to interruption of the blood supply to the femoral head. Ischemia resulting in aseptic avascular necrosis of the femoral head is a key pathogenic event in Legg-Calvé-Perthes disease. It is a self-limiting pediatric orthopedic condition. Imaging, necropsy and biopsy studies of patients with LCPD show evidence of tissue necrosis consistent with ischemic injury to the affected femoral head. According to recent studies, the cause of the vascular insult may be disturbed venous drainage, intraosseous venous hypertension, or increased blood viscosity leading to decreased blood flow. The anthropometric, epidemiologic, radiographic, and histologic evidence support the concept of a susceptible child. Perthes disease may therefore result from a generalized transient defect of epiphyseal cartilage due to its anatomically vulnerable blood supply. The most common signs of Perthes disease are mild discomfort in the hip joint, limping while walking, and decreased hip range of motion. Most commonly, the affected child presents with a history of slow onset limp. Most patients are active and asymptomatic even if their femoral head is deformed. Pain when present is usually activity related. It is usually mild and relieved by rest and analgesics. The pain is typically localized to the groin and may refer to the anteromedial thigh or knee region. Failure to recognize this referred pain to the thigh or knee may cause further delay in the diagnosis. Neglected children usually present with restricted hip motion, particularly for abduction and medial rotation due to a spasm of the adductor muscles. Long-standing adductor spasm may lead to adductor contracture. The Trendelenburg test is often positive. Most patients have evidence of disuse atrophy of thigh, calf and buttock due to inactivity secondary to pain. The limb length should be measured and any discrepancy indicates significant head collapse and a poor prognosis. The patient's height, weight and bone age may also help in the differential diagnosis. The initial diagnosis of Legg Calvé Perthes can be difficult unless a high degree of suspicion is maintained. Symptoms may be present on an average 6 weeks before the diagnosis is made. The period between onset of symptoms and diagnosis may be longer if the pain is mild or the patient presents late or the clinician is not alert. The diagnosis is generally made on the basis of the clinical and plain film findings. Radiographic changes of the femoral head, such as sclerosis, generally appear 6 weeks after the initial symptom. Therefore, in suspicious cases, a follow-up radiograph should be obtained after 6 weeks if the child is still symptomatic. After the diagnosis, follow-up is done by the anteroposterior and frog leg lateral film radiographs. The stage of the disease and the extent of epiphyseal involvement can be determined by serial plain radiographs. Based on plain radiographic appearances, the LCPD has been divided into 4 stages. A stage of avascular necrosis, a stage of fragmentation, a stage of regeneration or reossification or reparative phase, and finally the stage of healing or residual phase. MRI is indicated before surgery to determine if any flattening of the femoral head is already present, or how much subluxation is present, and how much surgical containment is necessary. The classifications for LCPD can be divided in 2 categories. One that defines the stage of the disease and the other that tries to predict prognostic outcome. 3 prognostic classification systems, namely Cathedral classification, Salter-Thompson classification and lateral pillar classification have been proposed based on the radiographic features during the stage of fragmentation. The Cathedral classification described radiographic head at risk signs that place the femoral head at particular risk and portend a poorer prognosis. Presently, the most used classification is Herring's lateral pillar classification. This classification system reflects the extent of the femoral head deformity. The main advantages of Herring's classification are that it is useful during the active stages of the disease and it allows accurate prediction of the natural history and treatment methods. In general, if the anterolateral portion of the femoral head is preserved, the prognosis is good. The factors that determine the treatment methods in Perthes disease include age of the child at the onset of symptoms, presence or absence of extrusion of the femoral head, range of motion of the hip, and a stage of the disease. Treatment of Perthes disease is best guided by the age of onset of symptoms. Children less than 6 years of age are seen to do best with non-surgical treatments. Between the ages of 6 and 8, similar results are seen with both surgical and non-surgical treatments. The results of surgery are best when performed shortly after the diagnosis rather than after a long time has passed. Treatment should be initiated well before the stage of fragmentation. Two factors widely used for treatment planning are the state of the lateral pillar as per Herring's grading and the extent of the epiphyseal deformation as per Caterer's grouping. The primary goals of treatment are to minimize femoral head deformity and maintain the roundness of the femoral head, and in this way to avoid the development of secondary acetabular dysplasia. This may be achieved by maintaining a good range of joint movement using analgesia, plaster, brace, a splint, physiotherapy, or by osteotomy surgery as required. The routine use of crutches and or wheelchairs promote a flexion or adductor posture. Hence, using these should be discouraged. Also, bracing on its own does not alter the natural course of the disease. The role of operative treatment is debated. Surgery may be performed early to prevent head deformation or late as a salvage when deformity is limiting movements. Young children rarely require salvage surgery because they get more time for the acetabular changes to result in an aspherical but congruent hip joint. Joint distraction or arthrodiastasis may preserve joint movement, but this has not gained popularity. Head flattening is a contraindication for most osteotomies of any type. The hip may seem to heal radiographically, but the change in shape of the affected hip and acetabulum may lead to secondary joint stiffness and loss of function in adult life. Thank you so much for watching. Please subscribe and stay tuned for more educational videos.